Good afternoon, everyone present here. I am Faraz from ITCP Group. Welcome all the participants on today's webinar. I would like to welcome today's topics webinar session guest with all your respect. He is none other than Professor Dr. Alulraj Sundaram sir, and let me share some of the achievement of sir. Sir has done MD, FRCP, PhD, DSc, Chairman on Head Acute Medicine, Sundaram Alulraj Hospital, Dr. S. Alulraj Healthcare Education and Research Foundation, Tamil Nadu, Honorary National Professor of Medicine, IMACGP, India, and past National President, Association of Physicians of Association of uh, Association of Physician of
Physicians of
India,
India.
API. So, today's topic is very important. That is a case of giddiness, unveiling pulmonary embolism. So, by taking not much time, I would like to invite sir and hand over this session to sir. Sir, the stage is yours. You can proceed from here.
Thank you. Thank you very much for the nice introduction. Warm good afternoon to all the participants. Now we are going to have a clinical discussion. So every time talking on a topic doesn't have much of a value. Ultimately, why science is taking place to only apply on the patient. Therefore, we have chosen to present to you a very interesting case. The presentation was different and the cost was different and management was fine. That is why this case has been chosen. Very commonly, we see a lot of giddiness patients in our practice. Here we have a patient who presented with giddiness and ultimately proved to be a pulmonary thromboembolism. We'll see how it happened and what it is. See, this is the complaint of the patient. A senior citizen, 68-year-old female, came to me with the complaints of giddiness and chest pain for one day, only one day. Since giddiness and chest pain were combined with that, the children were, very much worried and they brought her to me. There was no vomiting or postural changes. And the episode was in rest. And sometimes when she used to move also, she used to get it earlier. And now, there was some rest pain that I was also concerned. What is the history of the present illness? There is no history of a reeling sensation, imbalance while walking, or oral fullness, tinnitus, hearing difficulty, and there is no associated headache, vomiting, and then photophobia, and no weakness of the limbs, no palpitations, no arm pain, no sweating, and no breathlessness, orthopnea, or nocturnal dyspnea. The past history and the past history shows that she is a known case of hypertension for 5 years on regular treatment. She is a known case of hypothyroidism also on thyronorm, and she had a self fall at home around 15 days ago, and she consulted an orthopedic surgeon. They said that she is at a pelvic bone fracture and she is put on complete bed rest. And personal history, she was a housewife with sedentary lifestyle. Now, with this history of the present illness, the complaints, and the past illness, what are the possibilities we can think? Can be a peripheral vertigo, something like peripheral Barani vertigo, including a sinobronchial syndrome. Or can be a coronary artery disease, acute coronary syndrome. She has a chest pain, and earlier she had it on walking. Or any dysrhythmias can also be the cause for it. And a pulmonary embolism due to DVT. Since she is put to bed rest for a long time, there could have been a DVT and pulmonary embolism. And can be a posterior circulation stroke. One lady with hypertension can be a postural hypotension. These are the clinical possibilities that should pass through your mind as you analyze the complaints and history. A word about giddiness or dizziness, it is a non-specific terminology. It includes 4 components. Can be a vertigo or non-specific dizziness or a disequilibrium or a pre-syncope. Very important things. Now we'll need to find out to which category the patient fits in. There is an algorithm given for it. Pre-syncope, always you should think that it could be a cardiac cause, a dysrhythmia, or any medications, something like aminoglycosides, which are toxic to the vestibular system. May need an MRI to rule out a posterior circulation stroke also. Disequilibrium is always due to some neurological cause, either peripheral or central. Here also you may need an MRI. Non-specific dizziness can be a functional problem, or there can be a mild form of a vertigo. You will have to go with the clinical examination and auditory examination. And the vertigo can be a central or peripheral. Central, you will have a torsion or vertical nystagmus, whereas in peripheral, you have a side-to-side movement. It is very, very important. A neurological examination and an MRI will be needed to rule out any posterior circulation stroke here. These are the points in our mind, possibilities in our mind. We proceed with the patient. We detect general examination, the well-built, well-nourished, no pallor, icterus or cyanosis or clubbing, no masses anywhere. Ears were normal, external auditory canal was normal. Vitals were also normal, but she had a slight fall in blood pressure, which was around 90 to 60. Systemic examination, cardiovascular system S1, S2 are normal, but pulmonary second component was loud. Head and all area, no movements. Respiratory system fine, CNS fine, abdomen is also normal. Pelvic pain was there on moving the limb. These are the two positive findings. One is a pelvic pain on leg movement and a loud P2. And all the investigations, almost all were normal except three components. Blood sugar was little high, and IgT probably is coming up. Triglyceride was high. Liver function tests are normal. Tropi was positive, which always indicate there is a myocardial necrosis, can be a myocardial infarction. D dimer was high, 180. That shows always there is a pulmonary embolism or pulmonary thromboembolism. Coming to other investigation, ECG was taken, shows a sinus tachycardia, ST depression in lead 1, AVL, and lead 2, and some T wave diffuse changes are there. The classical change of S1, Q3, T3 that we see in the case of pulmonary embolism was not present here. There was some involvement of some STT changes which were little non-specific or maybe due to a hidden coronary artery disease. In X-ray chest, you see the patient has little cardiomegaly, probably secondary to old hypertension. And main important thing is the right pulmonary artery is very much bigger compared to the left. X-ray pelvis shows the fracture. Here is a fracture, here is a fracture. Shows a superior and inferior ramus of pubis. Fracture. There is a CT of the pelvis, shows a very clear, fracture. Here also a fracture. And this is very, very, very classical for a, fracture of the pelvis is a undisplaced fracture of right sacral ala also. These are the areas of fracture here. See it very well here. And coming to the echocardiography, if you see the echo, it's a apical four-chamber view. It's a right ventricle, left ventricle. This is a right atrium, left atrium. Simply anybody can see that the right ventricle and right atrium are markedly enlarged compared to the left ventricle and left atrium. She's a hypertensive lady. We expect the left heart to be enlarged. Here, right heart is very much enlarged. There is a gross tricuspid regurgitation. Here, tricuspid regurgitation is there. This, waves are very classical. Mild left ventricular hypertrophy, severe tricuspid regurgitation, no regional wall motion abnormality, severe pulmonary hypertension, RA-RV dilated, McConnell sign is positive. It is very classical. It is a right sided enlargement with akinesia of the mid-free wall of the mid-free wall of the right ventricle with normal or hyperkinetic apical portion. This is always indicative of pulmonary embolism. This was the clue. A sudden onset of a right atrial and right ventricular enlargement, and McConnell sign gave us the clue that the underlying cause for a giddiness and chest pain may be due to pulmonary thromboembolism. Immediately, the choices you should go for a pulmonary angiography, or now CT angiography is available. CT pulmonary angiography was done, showed a massive pulmonary thrombus in the bifurcations and both the right and left pulmonary arteries, and it is a gross pulmonary embolism. And when we were looking for the cause, fibrinogen, everything was normal. But when we did a venous Doppler on the legs, there was a large thrombus in the both lower limbs. Both lower limbs. Now the final diagnosis, ladies and gentlemen, it's settled. It is an acute massive pulmonary thromboembolism, secondary to a deep venous thrombosis in both lower limbs, secondary to immobilization due to the fracture of the pelvis ramus, silent CAD to be evaluated further, and hypertension, hypothyroidism, and dyslipidemia. This is a final diagnosis. The treatment offered is immediately when pulmonary hypertension, thromboembolism, D-dimer was high, and ECG showed an STT changes, and echo showed a McCollum sign. Immediately started on low molecular weight heparin and antiplatelets, antibiotics, and antihistaminics. And when the CT angiography showed a thrombus, a thrombolysis, intravenous thrombolysis with aloxin 30 milligram was given prior to thrombolysis, steroids, and then continued with low molecular weight heparin. Lupinase 60 milligrams subcutaneous BD for 5 days, and then shifted over to newer oral anticoagulant like rivaroxaban 10 milligram BD for 5 days. Now, a follow up of the case after 5 days, you see, if you could recall the old CT angiography, the entire thing was thrombosed. Now it has cleared well. In the leg also, the vein is much cleared of the thrombus. The deep venous thrombosis, which is the cause for pulmonary embolism, has cleared well. Now, coming to the discussion of it, when there is a pulmonary embolism suspicion, when the possibility clinically is low, D-dimer is usually normal. When it is raised, we should go for a CT pulmonary angiography. If the clinical probability is high, immediately you can go for a CT angiography. When thrombus is present, it's fine, or inconclusive, you can go for a leg ultrasound or ventilation perfusion scan, which we'll see. Pulmonary embolism is a blockage of an artery, either the main artery, bifurcation, or right, left, or the branches, and it can be due to blood clot, air, fat, amniotic fluid. Commonly, they present with shortness of breath, dyspnea, tachypnea, chest pain, cough, hemoptysis. In massive thrombus and embolism, you can have a cyanosis also. Dizziness is due to a decreased cerebral blood flow, and signs can be a pleural rub. When there is an infarct, the base of the infarct is hitting over the pleural surface. There can be a pleurisy, pleural rub, and pleural euphemism. Pleural effusion. Pulmonary component of second sound is loud, as heard in our case, showing that there is a pulmonary hypertension. Jugular venous pressure can be raised. Fever, low BP, fast heart rate, and fainting can always be there. How do you classify the pulmonary embolism? Massive, high risk pulmonary embolism. Usually the patient is very sick, critical, may lose the patient also. Its incidence is around 5%. Submassive with right ventricular dysfunction, it's called as 30. Then non-massive without right ventricular dysfunction, it is more common, safer for the patient. The risk factors are, any recent surgery, cancer, especially pancreatic, colonic, and tumors, pregnant women, and post-operatively when the legs are immobilized. The causes can be due to immobilization causing a stagnation of the blood, and can be factors in the vessel wall, an injury, endothelial injury, can be factors in the property of the blood. We call them as a procoagulant stage, and that is why we do a lot of hematological evaluations. There is a clinical scoring, that is the clinical signs and symptoms of thrombosis and pulmonary embolism, and then heart rate is raised, immobilization. When these points are there, we give 3 points here, 3 points here, 1.5, 1.5, and when there is a, sorry, when the score is above 4, high risk. Pulmonary embolism is very high. Less than 4, the risk is very low. There is a modified Welch square has also come recently. Here it is likely to be a pulmonary embolism when the score is more than 2, and unlikely it is less than 2. This is the way clinically we arrive at a diagnosis. But now with the CT angiography, all those things don't have much of a value. D-dimer is a very important test which is indicative of a thrombotic pulmonary embolism. Troponin values without myocardial necrosis or infarction can be little high in pulmonary embolism. ECG commonly shows a S wave in lead 1, Q wave in 3, and T wave also inverted lead 3. It is very classical. There can be right ventricular strain as in this patient. X-ray chest has some important signs. One is a Hampton's cum, another is Pala sign, another is Westmark sign. I'll just show you what are these signs. This is the Hampton's cum. This is a triangular shape, a wedge-shaped infarct, which is based on the pleura. There can be pleurisy, there can be pleural effusion also. The upper lobar veins are, prominent in, Westmark signs. And here, oligemia is, here there is a blockade. Therefore, this area is oligemic. This is called as Pala sign. Beyond that, there are two more signs also. Fleischer sign, prominent pulmonary artery. Westmark sign, pulmonary oligemia. These are all some radiological clues that will make you to suspect. Echocardiography, as we discussed, RV are dilated. The McConnell sign is very classical. CT pulmonary angiography is a gold standard, shows a filling defect. A ventilation perfusion scan, when CT is not possible, especially in pregnant women or people who cannot go to the CT scan department, we can do that. Here there are the ventilation perfusion ratio. Perfusion will be fine. Ventilation is deficient. Therefore, there are 4 levels we try to analyze it: high probability, intermediate probability, low probability, and a normal scan. High probability scan always has an 88% chances that it could be pulmonary thromboembolism. This is the normal perfusion, normal ventilation. Here in the perfusion there is a defect, here ventilation is little defect. Here all there are infarctions, pulmonary infarctions. Pulmonary angiography is the gold standard. Directly you put in a catheter, do an angiogram. You can also try to remove here. Here there is it's an invasive procedure. These are the anatomies. This is the invasive pulmonary angio, which shows multiple thrombi in the main pulmonary artery. And suppose we are not able to, dissolve the thrombus with a lytic therapy, you may go for a pulmonary thrombectomy, especially when we have done a pulmonary angiography. We can go for an intra-arterial thrombolysis also. You can give the drug intra-arterially and see that this is, coming out. And sometimes, we can also put in a catheter and try to evacuate the thrombus, called as an intra-arterial thrombectomy. These are all invasive procedures, very rarely needed, but we should be aware of it. What is the course of the patient in the hospital? This 68-year-old female patient presenting with chest pain and giddiness, initially treated as coronary artery disease, CT angiography and elevated D-dimer levels and dilated RA, RV in echo, diagnosed acute pulmonary thromboembolism secondary to both leg DVT due to immobilization. Thrombolized and started on low molecular heparin, followed by Novak, discharge in a stable condition. Coronary angiography is planned for on review with the chest pain and ECG changes and tropo elevation. Now, the pulmonary thromboembolism can have certain complications. Can have a right heart failure, post-thrombotic syndrome, that after thrombolysis, that's the chronic pain, swelling, and other signs in the affected limb. Post-pulmonary embolism syndrome, they can also have some dyspnea, exercise intolerance, and reduced quality of life. Recurrence is very common. 10% of cumulative, 10-year cumulative risk is 23%. And therefore, we should be very careful that the deep vena thrombosis doesn't occur. If the veins, the thrombus doesn't clear, there is a procedure called as inferior vena cava filter. From the leg, the veins comes to the femoral vein, it comes to external iliac vein and IVC. From IVC only it goes to the heart. We can block it there by putting a filter, and the clot that is getting accumulated on the filter can also be removed. This is the process we do. There is a D-dimer. Based on that, we try to go for a CT angiography, which we already discussed here. Now, the treatments available is the thrombolysis. As I told you, non-invasive intravenous thrombolysis. And in the submassive PE, yeah, it is always useful. There we may have to do a pulmonary thromboembolectomy, surgical or catheter-based for patients with bleeding risk and massive embolism. Anticoagulation, low molecular weight heparin and Novak IVC filters, as I told you, for prevention. Why we are discussing on this case? Elderly female with a fall, prolonged bed rest, complaint of chest pain and palpitation. Tropoid D dimer were elevated, echo showed dilated RA and RV and pulmonary hypertension. Doppler showed a venous thrombosis, CT pulmonary angio showed a massive pulmonary embolism, and it got thrombolized and then improved and discharged stable condition. Presenting with giddiness is due to reduced blood flow. Coexisting coronary artery disease must be remembered and must be taken care. Now, what are the learning points from this case? Every dizziness is not vertigo. Everybody says it is dizziness. You don't think that it is only vertigo. Don't take a smooth view. All chest pain is not acute coronary syndrome unless there is a evidence, either ECG or echo. Elderly patients with prolonged bed rest leads to DVT and embolism. Sudden increase in size of RA, RV, suspect pulmonary embolism. It's a treatable and preventable condition. Pulmonary thromboembolism, ladies and gentlemen, is a pan-cardiovascular syndrome. I think I have made the point very clear here and why this case is being presented, how the presentation was there, how it was evaluated, how treated. I think I have conveyed you the message. Thank you all very much. Any inputs from the audience, I love to hear. Hello?
Thank you so much, sir, for taking out your important time and sharing your knowledge on this topic, sir. I definitely think this session knowledge is going to help all the participants on their practice also. Sir, I can see, sir, we have received a few questions, sir. With all your permission, shall we take these questions one by one?
Please, please, go ahead.
The first question I can see is from Dr. Subramaniam, and he is asking,
Hmm.
sir, what are the challenges in choosing between direct oral anticoagulant DOAC and vitamin K antagonist, example warfarin?
See, here the problem is vitamin K antagonists are. The problem here is it takes 4 days to act, and control is also very difficult. You'll have to keep on monitoring the INR. Whereas with NOAC, it immediately acts. And if you want to stop also, the action stops within 24 hours. And no regular PTINR is needed. And much safer also for the people. Therefore, I for the one who prefer, especially for these, major cardiovascular events, a novel oral anticoagulants only.
Thank you so much, sir, for sharing an insight for that question, sir. Moving forward, we have another question, sir, from Dr. Chatterjee. He is asking, what factors determine the prognosis of PE and what scoring system, that is PESI score, can be used, sir? Could you please highlight some of them?
I don't understand the question. Can you tell me again?
The question I can see, sir, what factor determine the prognosis of PE and what scoring system, that is PESI score, can be used, sir?
PSI score, I am not aware of it. A scoring system for pulmonary embolism I already given. Wells scoring system and modified Wells scoring system. These are the only things we apply. See, these are all only theoretical. Clinically, when there is a D dimer elevated, you will have to always suspect a pulmonary thromboembolism. Look for a venous thrombus. And if there is a cardiac problem, you will have to look for a echo, a right side cardiac enlargement. If need be, gold standard is a CT pulmonary angio. Make a diagnosis, start with a thrombolysis and maintain with anticoagulants, and then oral anticoagulants. Yes, Yeah, next question. Hello?
Can you hear me, sir?
No, now I am
Uh,
able to hear you.
yeah, yeah, thank you so much, sir, for sharing the insight on that question, sir. One last question I can see from Dr. Ashish Pal, and he's asking, kindly share what is the role of IBC filters in PE prevention, and when should they considered, sir?
IVC filters, inferior vena cava filters, are needed only when there are three indications. One is when there is a recurrent pulmonary embolism. Secondly, even after oral anticoagulants, the venous thrombus in the legs is not coming out. Number three, when there is an extension of the venous thrombosis through the external iliac vein to IVC. In these situations, IVC filter has to be there. The common indication is a recurrent pulmonary, recurrent deep venous thrombosis. In those people, in spite of an oral anticoagulant, in these people, inferior vena cava filter is a must.
Thank you so much, sir, once again, sir, for sharing your insight on that question, sir. I can see one feedback from Dr. Subramaniam. He has written, thanks for answering my question and wonderful case study. Thanks for bringing us awareness among us.
Okay, then shall I leave?
Yes, sir. As I can see, sir, there is no more questions, sir. Shall we conclude this session with all your permission?
Please conclude.
Thank you
Thank you.
so much, sir. We would
Thank you.
like to see you in future also with different topics, sir. Till then,
Sure.
take care of
But
yourself,
there
sir.
should be the questionnaires video and the guest speakers video must be available, which is not coming
Sir,
here.
it will come, sir. We will share the.
And it is not coming. When it is there only, it will be easy for us to understand. This must come on the side. In every meeting digitally, when I appear, these types of things will come. In your thing, it is not coming. Only the PowerPoint is coming. Either at the top or the side, they should be available so that it will
Yes, sir.
ease our communication. Okay. Next time,
Thank you
take care.
so much.
Thank you so much.
Yes, sir.